Assalamu alaikum. Now we move on to our second session. I'm Dr. Bushra Ahsan from Shaukat Khanum Memorial Cancer Hospital and Research Center. I'm the moderator for this session. We have two speakers and they're both online. The first speaker is Dr. Kiran Naqvi. She is a hematologist oncologist from MD Anderson Center. She's an associate clinical professor of medicine. She will be giving a talk on how I sequence treatment of ALL in adults, Philadelphia positive as well as Philadelphia negative. So the first talk, please.
Hi, good morning and good afternoon, everyone. This is Dr. Kiran Naqvi. I'm an associate clinical professor of hematology and oncology at the University of California, Irvine. I would like to thank the organizers for allowing me to present how I sequence treatment of B-ALL in adults. I do not have any disclosures. Here are the learning objectives of today's talk. We'll be discussing the role of novel agents such as blinatumomab and inotuzumab in patients with B-ALL. We will also be discussing lower intensity approaches in the elderly patients, followed by discussion on the role of TKI therapy as well as chemotherapy regimens in pH-positive ALL. And we will finally also touch upon and review the role of MRD testing by NGS or clonoSEQ in ALL. While in the first 2 decades of the 21st century, the intensity of chemotherapy for patients with pH-negative ALL has tended to increase, this trend may reverse in view of the results of modern studies incorporating immunotherapy to the first-line treatment. A series of phase 2 studies have demonstrated feasibility of adding either blinatumomab or inotuzumab or both in combination or in sequence with standard chemotherapy. So I would begin with this first study conducted at MD Anderson. It's a phase 2 study of hyper-CVAD followed by sequential blinatumomab. This is the study design. As you can note that the age of the patients enrolled in the study was 18 to 60 years. Patients initially received intensive chemotherapy consisting of 2 cycles of hyper-CVAD, alternating with 2 cycles of high-dose methotrexate and cytarabine. During the intensive phase of the study, all patients received 8 intrathecal chemotherapy injections for CNS prophylaxis, and patients with CD20 expression of 1% or more of the leukemic cell received 8 doses of either ofatumumab or rituximab. All patients then went on to receive 4 cycles of blinatumomab with the standard treatment schedule used in previous studies. The maintenance phase consisted of 12 monthly cycles of POMP with 3 additional cycles of blinatumomab, as you can see highlighted in orange. And patients were allowed to undergo stem cell transplant if they were eligible. After observing the relapses during the chemotherapy phase in the patients with high-risk features, an amendment to the protocol was made to allow early administration of blinatumomab after 2 cycles of chemotherapy in patients such as pH-like ALL, low hypodiploidy, near triploidy, and patients with MLL gene rearrangement. The main differences between the hyper-CVAD plus sequential blina schedule and the standard hyper-CVAD was the administration of 4 intensive chemo cycles instead of 8, and then administration of a shorter maintenance of 12 cycles of POMP. So after enrolling 38 patients in cohort 1, which was hyper-CVAD, followed by sequential blinatumomab, another amendment was made to the study and inotuzumab was added in cycles 2, 4, 6, and 8. The dose of inotuzumab, you can see, was 0.3 milligrams per meter square on days 1 and 8 in cycles 2, 4, 6, and 8. And during these cycles, the dose of methotrexate and Ara-C was reduced because of concomitant inotuzumab. Here are the baseline characteristics of both the cohorts. The median age was 33 years, and 27% of the patients were noted to have high-risk disease by cytogenetics. The complete remission rate after induction on protocol was 84% when excluding the 16 patients who were already in CR at study entry. All patients achieved CR during treatment, and 43 patients achieved MRD negativity after induction chemotherapy on protocol. The median time to MRD negativity was 21 days, occurring for most patients after 1 cycle of treatment, and there were no early deaths noted on the study. Please note that with the shorter follow-up of cohort 2, 3 patients were seen to have relapsed in the chemo blina inotuzumab arm versus 11 patients in the chemo plus blina arm. There have been So far, no deaths in the chemo blina inotuzumab arm versus 9 deaths in the chemo blina arm. The overall survival remains significantly high even with chemo plus blina arm, with the 4-year overall survival you can see here as 82%. This benefit of adding blinatumomab to chemotherapy was further confirmed in this phase 2 study by the Jemima, where they studied sequential chemotherapy and blinatumomab to improve MRD disease in adult Philadelphia negative BLL patients. This is the study schema, and you can see that the primary endpoint of the study was MRD negativity after first blina administration. 149 patients were enrolled in the study, and the median age of the patients was 41 years. 19% of the patients were over 55 years of age, and about 50% of the patients had adverse risk disease. Blina was noted to improve the rate of MRD negativity from 72% to 93%. This figure shows that the 3-year overall survival rate was 71%, while the disease-free survival rate was 65% when blina was added sequentially to chemotherapy. The survival outcomes, however, remain poor in older patients above the age of 55 years, as you can see in the lower graph. Then here's the study design of the phase 3 E1910 study that was presented in the plenary session a couple of years ago at ASH that finally led to the approval of blina in combination with chemotherapy in consolidation for Ph-negative BLL. 224 patients with MRD negative CR after receiving pediatric-inspired regimen were randomized in a 1-to-1 fashion to receive chemotherapy with or without blinatumomab as part of consolidation. 20% of the patients in each arm underwent allogeneic stem cell transplant. In the MRD negative population, the blinatumomab with chemotherapy significantly improved survival relative to chemotherapy alone. Notably, deaths from both relapsed and non-relapsed mortality were increased in the chemotherapy arm. The frontline blinatumomab consolidation, regardless of MRD status, is now the new standard of care in Ph-negative BLL. The study also demonstrated that the survival benefit of adding blinatumomab to chemotherapy in consolidation occurred in those receiving 4 cycles of blina. There was no difference noted in outcomes in patients who received 1 to 2 cycles of blina compared to the control arm. While the survival outcomes of young patients with BALL with intensive chemotherapy remains encouraging, in the older patients, the survival rates remain significantly low, with a 5-year overall survival rate of around 20%. This is mainly because of the high rates of chemoresistance in the older population because of disease biology, and as well as poor tolerance to conventional chemotherapy. There is currently no clear standard of care in this patient population. This slide shows the most recent design of the phase 2 trial being conducted at MD Anderson, which incorporates both fractionated lower doses of inotuzumab and addition of blinatumomab to the lower intensity chemotherapy. Beginning with patient 50, patients went on to receive 4 cycles of hyper-CVD plus inotuzumab, which is given in fractionated dosing on days 2 and 8. The total cumulative dose of inotuzumab is 2.7 grams per meter squared with this modified design. This table shows the responses observed. The overall response rate was 99% with a complete remission rate of 89%. Only 1 patient did not respond to the regimen. Despite an older population with a median age of 68 years, no early deaths were observed in the study. The MRD negativity rate at day 21 of the first cycle was 85%, and 94% of the patients achieved MRD negativity at any point over the course of therapy. This figure shows the progression-free survival and the overall survival of the entire cohort. The median progression-free survival is 41 months. The median overall survival is 45 months with a 5-year overall survival rate of 46%. This compares favorably with the historical 5-year survival rate of only 20% in this older population. Moving on to the SWOG study, the SWOG 1318 study, this evaluated blinatumomab without any chemotherapy in induction as well as consolidation therapy, followed by prompt maintenance in older patient population. These are the baseline characteristics, and you can see the median age of the patients in this study was 75 years. 19 of the 29 patients that were enrolled on the study achieved a CR. The 3-year disease-free survival with just blinatumomab followed by POMP maintenance was 37%, and the overall survival, the 3-year overall survival was at 37%. This was followed by the Alliance study 041703 trial. This is also chemo-free regimen but instead of the blinatumomab used in induction and consolidation, this regimen started off with inotuzumab as an induction, followed by blinatumomab. Patients in this study were above the age of 60 years of age. In this study, patients received single agent INO times 2 cycles in induction, followed by 4 to 5 cycles of blina consolidation. In this older population of patients receiving chemo-free regimen, they were noted to have high CR rate of 85%, of 96%, and 1-year event-free survival of 75% and overall survival of 84%. Moving on to the Philadelphia positive ALL, studies have shown that the survival benefit with TKI therapy is added. There is survival benefit when TKI therapy is added to chemotherapy in patients with Ph positive ALL. With improved molecular responses and survival, regimens are now being tested, minimizing chemotherapy or completely excluding chemotherapy from treatment regimens. The benefit of combining imatinib with chemotherapy was first demonstrated by the MRC ECOG group. The addition of imatinib here resulted in the superior CR rates, you can see of 39% and 26%, and overall survival, especially when added early during induction. Survival was improved with transplant in first remission with a survival rate of 50% versus 19% when patients did not receive a stem cell transplant. The SWOG also conducted a study where they demonstrated improved outcomes when dasatinib was combined with chemotherapies like hyper-CVAD. Survival was improved also in patients who went for transplant in first remission, as you can see in the landmark overall survival by transplant. However, the relapses were noted with up to 75% of the patients harboring a T315I mutation when treated with imatinib or dasatinib. And so this mutation, as we all know, confers a resistance to all TKI except ponatinib. So the next study, which was conducted at MD Anderson, exactly tried to evaluate ponatinib in combination with hyper-CVAD in this phase 2 study. The figure shows the response rates and the event-free survival and overall survival of the entire cohort. And neither the median event-free survival or overall survival has been reached, while the estimated 5-year event-free survival with hyper-CVAD ponatinib was noted to be 68%, and overall survival rate of 74% respectively. To evaluate the impact of transplant in patients treated with hyper-CVAD plus ponatinib, the investigators performed a 6-month landmark analysis, which was the median time to transplant in this cohort. Interestingly, there was a strong trend towards better survival in patients who did not go for transplant compared to those who did receive a transplant. The 5-year overall survival for non-transplanted patients was noted to be 83% versus 66% for those who actually went to transplant in first CR. The p-value was 0.07, and the difference in outcomes was largely driven by transplant-related deaths observed in this latter group. Similarly, no benefit with transplant was noted in survival outcomes in patients achieving a complete molecular response at 3 months, as you can see here. And while allogeneic stem cell transplant resulted in lower relapses, a higher non-relapse mortality in transplant was noted. The Falcon study with the schema over here demonstrated the benefit of ponatinib over imatinib when combined with reduced intensity chemotherapy. Here is the primary endpoint, which is MRD negativity by PCR of BCR-ABL of less than 0.01 CR at the end of induction. Patients in the ponatinib arm were noted to have higher MRD negative rates of around 34.4% versus imatinib, which was 16.7%. Ponatinib also resulted in superior progression-free survival when compared to imatinib, combined with reduced intensity chemotherapy. In the DELVA study, the investigators proceeded with a chemo-free regimen where they combined dasatinib to blinatumomab. Here is the study schema. You can see that the initial 85 days, patients were treated with dasatinib and steroids, and this was followed by blinatumomab for 2 cycles. 63 patients were enrolled in this study. 29% of the patients achieved molecular response at day 85 plus with dasatinib plus steroids alone, and this improved to 75% after completion of blina in combination with dasatinib. The estimated 4-year disease-free survival rate was noted to be 76% and overall survival of 81%. This chemo-free regimen is very similar in outcomes with hyper-CVAD plus ponatinib with less toxicity. This chemo-free regimen of dasatinib plus blina was also evaluated in older patients and resulted in higher 3-year disease-free survival and overall survival. MD Anderson also conducted a phase 2 study where they combined blinatumomab with ponatinib. Here is the visual schematic of the ponatinib plus blinatumomab. Patients receiving an induction cycle of ponatinib 30 milligrams daily along with standard dose blinatumomab on a 4-week on, 2-week off schedule. Patients then went on to receive up to 4 consolidation cycles of this regimen, followed by maintenance ponatinib for 5 years. Notably, the ponatinib dose was decreased to 15 milligrams daily once the patients achieved a complete molecular response. All patients went on to receive 12 doses of intrathecal chemotherapy. This table shows the responses observed. The overall CR/CRI rate among evaluable patients was 97%, and of note, there was only 1 early death on the schedule with this regimen. Among the evaluable patients, 83% achieved a complete molecular response, and 67% of the patients achieved complete molecular response after 1 cycle of therapy. 98% of the patients were MRD negative by clonoSEQ or next generation sequencing MRDSA. The median follow-up is 24 months, and the estimated 3-year event-free survival is around 77%, while the 3-year overall survival is 91%. Moving on to the last part of the talk, which is the role of MRD in B-ALL. Here we see the prognostic impact of MRD in our patients with B-ALL. A meta-analysis of 39 studies was conducted. This included over 13,000 patients with all ALL subtypes. And MRD clearance clearly was seen to have a prognostic impact, which was consistent across all therapies, MRD method, timing, and level of cutoff and subtypes. Next generation sequencing based assessment of MRD in ALL, this NGS MRD assay first sequences the VDJ region of the B and T cell receptor genes from pre-treatment samples in order to identify dominant rearrangements that can be used for tracking purposes in latest samples. These VDJ regions are unique to a specific clonal population of cells and provides a quantifiable molecular barcode that is stable over the course of therapy and can directly quantify leukemic cell burden. Dr. Short from MD Anderson published in Blood Advances a couple of years ago the concordance between MRD testing by flow and MRD testing by next generation sequencing in patients with Philadelphia positive and negative ALL. In PH negative ALL, he noted that all patients who tested positive for MRD by flow cytometry were also positive by NGS. However, 46% of the patients who were tested negative by the multicolor flow cytometry, they actually tested positive for MRD by NGS. Patients who tested negative for MRD by NGS none of them relapsed, as you can see in the blue curve here, while patients who were tested positive by NGS, they had up to 27 relapses with a 5-year overall or cumulative incidence of relapse of 46%. Here you can see that patients who are negative by NGS, who are MRD negative by NGS, and with superior overall survival compared to patients who are still MRD positive by NGS. In Philadelphia positive ALL patients, he noted that patients who tested positive by MRD by PCR and compared it to MRD, he tested MRD testing by PCR for BCR-ABL and compared it to MRD testing by the NGS. In the first graph on the left, we can see that patients who tested negative for MRD by NGS at 6 months, or in the first 6 months, they had a higher relapse-free survival compared to those who tested positive. The concordance was 68% between MRD testing by NGS and by PCR. Please note that once the patients achieved MRD negative by NGS, there was no prognostic impact of PCR, either positive or negative, in these patients. So in conclusion, integration of novel monoclonal antibodies into frontline regimen allows for a use of less chemotherapy, higher rate of MRD negativity, and less reliance on stem cell transplant, and higher cure rates. Chemoimmunotherapy is highly effective in our patients with B-ALL. Intensive chemotherapy followed by sequential blina in younger ALL has resulted in a 3-year overall survival of up to 80 to 85%, while hyper-CVAD with inotuzumab, with or without blinatumab, in older ALL patients had resulted in a 5-year overall survival of 46%. Chemotherapy-free regimens are also being explored in some groups. In Philadelphia positive ALL, dasatinib with blinatumab has resulted in a 4-year overall survival of 81% by the DELBA study, while a study at MD Anderson where they combined blina and ponatinib in PH positive ALL resulted in a 3-year overall survival rate of 91%. INO and blina combination by the Alliance study has also shown improved survival in patients over the age of 60 years. So the role of stem cell transplant is actually diminishing with better frontline therapy and high sensitivity NGS MRD monitoring. Thank you again. If you have any questions, please let me know. Thank you.
Before we move on to our second talk, we just want to make sure the chair of the session, Dr. Natasha, is she online with us? So our chair is Dr. Natasha Ali. She's a professor, hematologist, oncologist, and bone marrow transplant physician from Aga Khan University Hospital. We're just confirming if she's online with us. Yeah. So we'll move on to our second talk. That's Dr. Aamir Ehsan. He is a renowned hematopathologist and molecular geneticist with more than 25 years of experience. He is the director of CorePath Laboratories in Ohio, USA. He's going to talk about how to incorporate genomics in management of hematological malignancies.
Hello, Assalamu alaikum, and good morning. This is Dr. Aamir Ehsan from San Antonio, Texas. First of all, I would like to thank the organizing committee for putting this wonderful program together, a very comprehensive program, and giving me an opportunity to talk about the topic listed on the slide. I'm a board-certified hematopathologist and molecular geneticist and the medical director and CEO of CorePath Laboratories in San Antonio, Texas. I have put together a few slides and hope to cover a very extensive topic within 20 minutes, highlighting the key components of the session. So the topic is how I incorporate genomics in the management of hematologic malignancies. So basically, this is a list of the WHO classification and of course, all the diagnostic side and all the diagnostic testing is based on the WHO classification. You can see the list. I don't want to go through the list, but as you can see, it's a pretty comprehensive listing over here. Keeping in mind, whatever I'll be talking will be related to the most recent WHO classification for hematolymphoid malignancies. The genomic medicine or the genomics by itself incorporate cytogenetics, fish analysis, as well as the molecular genetics, of course, which include the PCR as well as next generation sequencing. For the sake of discussion and for the sake of this lecture, I'll be talking mostly about the molecular genetics rather than cytogenetics in fish. So the goal of any diagnosis using the genomic testing is correlate the pathological and clinical information using the current nomenclature and guidelines. Basically, the purpose is three. Are these tests helpful in making the diagnosis? Are these tests helpful in the treatment outcome? And can we predict the prognosis based on the results? Coming back to the basic schematic diagram before we go into the molecular genetic testing is, as we all know, that the DNA has a pretty wide variety of mutations spanning throughout. And once it's transcribed, the RNA is formed and mRNA eventually leading to the protein. So it's the exploitation of protein or mRNA or the DNA which actually form the basic concept of the genetic testing. So keep this slide in mind and as we discuss further along. So one of the questions get asked is, do I need to do single assays which are PCR, or do I need to do the next generation sequencing? It really depends where you are practicing, how are other logistical challenges, and we'll try to cover some of those basic items. So basically, molecular genetic testing are divided into DNA-based platform or RNA-based platform. Some of the testing that I have listed here are in two of those categories. However, there are cases, especially in NGS, where both DNA and RNA-based testing is needed. So molecular testing, talking about next generation sequencing, another question which is asked is, do I need to do few genes or many genes, and what is the right number? I don't think when we are practicing science and when there is a patient right in front of you with a diagnosis of cancer, that we need to limit our knowledge to few genes testing, as you know that every day new pathogenic mutations are being identified. When we are running the NGS, it does not matter whether you do few genes or many genes. The library prep and all the detailed aspects of the analysis is essentially going to be the same. So rather than pigeonhole ourselves into few genes versus many genes, let's talk about the NGS, the concept of NGS and hematologic malignancies. So I have listed 4 common things as we get the sample of blood or bone marrow. The question is being asked in the mind of the hematopathologist is, are we dealing with myeloid disorders? Myeloid means MPN or MDS. Most of the time in those disorders, we are going to be ordering the DNA-based NGS testing. If we are dealing with acute leukemias, it's ideally both the DNA and RNA expression or sequencing is being ordered, because you never know what kind of leukemias you are dealing with and how different kind of mutation can affect the patient outcome. Lymphomas and myelomas, it's not the standard of care currently to do the NGS. Sometime in high-grade lymphomas and certain myelomas, these tests are being offered at certain academic center. But traditionally or typically, such DNA and RNA testing is not standard of care these days. Liquid biopsy is becoming more common, mostly in solid tumor and in MRDs. But there are a few examples of doing liquid biopsy, looking at DNA and RNA in hematologic malignancy, especially in pediatric population, or sometime when you have limited bone marrow or the bone marrow is dry tapped and you don't have much to go with. And the best thing is just to obtain the peripheral blood or do the liquid biopsy. Even though liquid biopsy in hematologic malignancies is being offered, but this is not a typical scenario in most of the time. So molecular testing, especially practicing in United States, some of the aspects might not be relevant in Pakistan based on the various logistics. When we are doing all these molecular testing, the question we ask ourselves is it going to affect the diagnosis, a treatment option, prognosis, and can we do this for MRD? What is the expected turnaround time? I know that in certain acute leukemias, a few mutations need to be known within few days, first 5 days of the diagnosis, like IDH1, IDH2, FLT3 kind of mutation. And while you're doing the full NGS, the early or preliminary result can be given to the oncologist or hematologist to make appropriate treatment decision. In United States, pre-authorization is a big thing. That's what the challenge is, that we cannot really go for the pre-authorization in hematologic malignancy because we're dealing with a lot of unknowns. So that's a challenge by itself. I don't want to go into that detail. Of course, whatever testing we are doing need to follow the NCCN guidelines. It's kind of interesting to know that even though these are standard of care, but from the insurance point of view, most of these tests are still considered investigational, and that's why there are a lot of reimbursement challenges in US. So what is the take-home message when we are talking about molecular testing? The take-home message is anytime you're doing a bone marrow, ideally you need to do the bone marrow morphology, flow cytometry, and cytogenetics. You don't need to do the molecular testing upfront on the day of the bone marrow biopsy. Wait for the morphology, perhaps hold the sample for a day or two, and after that make the determination that whether FISH is needed, molecular studies, or certain stains, without affecting the sample integrity. So this is one of the sample of our CorePath report. As you can see, we do release several independent reports, but at the same time, on one page, we summarize these reports, morphology, flow cytometry, cytogenetics, FISH, and molecular, even though the molecular is not shown here. But one page give you more integrated approach to what's going on with the patient rather than going into the detail of every report. So this is what I did for the simplicity of how to triage blood or bone marrow when doing the testing. On the left-hand side, you are seeing leukemias, lymphomas, MDS, MPN, and so on and so forth, especially cytopenias and cytosis. And there is no really textbook that specifically give you such tables, so this is pretty handy for the audience. Basically, flow cytometry is usually done in pretty much all kind of scenarios, as well as cytogenetics. However, the triaging decision is based on earlier findings based on flow, and whether H means like holding for certain testing. So this kind of give you a good idea of different disease categories and what approach you need to take while triaging the bone marrows. So I'm going to take time and talk about clinical scenario using the concept of what we do at CorePath, which we call 2020 core evaluation. So let's say we have a patient who is 70 years old male presented with pancytopenia. Now, we cannot order NGS or molecular testing or genomic testing right off the bat on this particular case. So morphology was seen and was evaluated, and features of dysplastic erythroids and dysplastic megakaryocytes were seen on the bone marrow morphology. And a good number of time, the cytogenetics in FISH can be negative. So if the logistic allow and the reimbursement and all those kind of things, the ideal thing is to perform the NGS, the DNA-based testing, because we are dealing with myelodysplastic syndrome, and a good number of cases can be cytogenetics and FISH negative. Another scenario is you are dealing with a 55-year-old female with leukocytosis, thrombocytosis, anemia. Of course, this is a proliferative disorder. Looking at the bone marrow is hypercellular. And after ruling out the secondary causes, morphologically, it's kind of concerning. A simple BCR-able test was negative. That kind of ruled out chronic myeloid leukemia. And now we are dealing with a list of myeloproliferative neoplasm. And rather than doing a single single gene assay, at least on the Western world side, we do an extensive NGS panel, mostly DNA-based test. So the first was the MDS. This is more MPN. And in my earlier slide, we were dealing with myeloid disorders. So the NGS using the DNA testing is going to be a better approach here. The third scenario is bone marrow was performed on a recently diagnosed case with Burkitt's lymphoma. The bone marrow is involved, morphology is there, and flow cytometry is also there. Now, in this particular case, since we already have the diagnosis established, this is a staging bone marrow, there is no need of doing any molecular testing in the bone marrow. However, if this is the initial presentation and this bone marrow is a diagnostic as well as staging bone marrow, then you may need to do some genetic testing. Not extensively for lymphomas. For Burkitt's, you can do a FISH analysis just to document that there is a presence of CMEC and double hit other profile as well. The fourth scenario is CBC showing many circulating blasts, and here most likely we are dealing with acute leukemia. If the flow shows AML or ALL, both are acute leukemias. After you rule out APL by doing a FISH analysis for PML RAR, this is a good example of a case that we need to do both DNA and RNA expression profile or sequencing for acute leukemias by next generation sequencing. Another scenario, we have a patient with abdominal mass and pancytopenia. The bone marrow is involved by a lymphoproliferative disorder. Hopefully, the diagnosis was already made in the mass, but if this is also the diagnostic sample, then most of the time the morphology and immunohistochemistry and flow cytometry is helpful in making the diagnosis. So if it's more like a lymphoma-based diagnosis, then NGS is not needed, as other ancillary testing is enough to make the final diagnosis. Another case of a multiple lytic lesion and M spike, of course, sound more like a multiple myeloma. This particular case, flow cytometry, immunohistochemistry, and FISH analysis is really going to be helpful. There are some academic centers that are doing the next generation sequencing in myeloma, but most of the time we pretty much do basic workup, including FISH studies. Another case of a post-transplant for ALL, day 30 pancytopenia. Of course, this is something that you have been following. There may be all the studies that have been done before transplant. So at this point, there is no need of doing genomic testing unless you are looking at chimerism based on allotransplant. But typically at this point, no NGS testing needed for the diagnosis or the treatment point of view. Hopefully, I cover very quickly all the aspect of the NGS. I think as I practice hematopathology and molecular genetics, there are a few things when I look at the bone marrow with my colleague is coming back to the three things that I mentioned earlier, the diagnosis, the treatment, and the prognosis. If any of the testing that you order on these cases, you need to make sure that it's making clinical sense. And looking at the WHO classification, you broadly categorize your disorder into myeloid, MDS, and MPN. So you focus on NGS for DNA.
Thank you very much, Dr. Ehsan. Dr. Ehsan and Dr. Natasha are online, and we have our worthy panelists here as well. So if you have any questions or any comments. Dr. Natasha, would you like to say anything? We can't hear you. Either you are not mute or...
I could hear her.
Yes, we can hear you now.
All right, great. So thank you so much for the opportunity, and my apologies I couldn't be there in person. But thank you so much, and thank you to both the speakers. I think we had a great, a comprehensive review on the treatment of really positive and negative acute lymphoblastic leukemia. We have quite a good experience of using immunotherapy and blinatumomab in Pakistan, especially in the pediatric population. The experience is growing with the availability of the drug. There's a program here where the pediatric population receives the drug free of cost, and we use it quite a lot in our center. Even in the adult population now, we are turning to use immunotherapy, especially in patients with relapsed and refractory leukemia. So thank you so much for that, and I'm sure as our data keeps maturing, we will finally wait and see how the older population responds to this drug. And we've not really tried that here at the moment, but I'm sure the data is still maturing, and maybe next year we may present something on that. For the next talk, Dr. Aamir, thank you so much for doing that review. We know that leukemia diagnostics are impossible without the molecular testing, and we have a 55 gene panel that all the clinical hematologists in Pakistan do send out their samples to. And yes, and the basic tests and the basic scenario that you mentioned, we see that day in and day out. So both the talks were bang on target, a very, very updated review, and I'm sure the audience has a lot of questions on that.
Thank you. Do you have any question, Dr. Mehri?
Thank you, Dr. Aamir Ehsan, for such a wonderful talk. As we all know that WHO has incorporated molecular testing in almost every kind of malignancies of hematological disorders, in diagnosis as well as in prognosis. But it is certainly easier said than done, as far as a resource-poor country like Pakistan is concerned. So, especially in the current scenario where we don't have any established genetic database of our own population. One of the main problems while running an NGS panel is the interpretation of number of variants that we get. So my question is basically, is there any tool which can predict the impact of VUS in personalized transplant care patients or anything like that, which can actually help us in determining whether that VUS is significant in our population in that particular disease context or not?
Yeah, can you hear me?
Yes, we can.
Yeah, that's a great question. Actually, I think this forum and this great networking of people is going to be a very good initiative for having this kind of opportunity in Pakistan, because every geographic population is going to be very unique, right? When it comes to hematolymphoid and all these variations. I think if we use the certain hotspot genes that are more relevant, that we know that precision medicine, the treatment can be offered in Pakistan. We need to have a very strong bioinformatic pipeline and certain tools that we typically use various AI-based intelligent model for analysis and access to the public database. So it's going to be a unified approach if all the institution and we can establish some sort of centralized database source using certain AI tools. I think that would be the initial first step strategy.
Can I have a question? Thank you very much, Dr. Kiran Naqvi and Dr. Aamir Ehsan, for excellent talks, and thank you very much, panelists. So my question is to Dr. Kiran Naqvi. As you said, the role of allogenic hematopoietic stem cell transplant is diminishing gradually with the passage of time for Philadelphia positive ALL. So my question is, previously all Philadelphia positive ALL were candidate for transplants. Now, if we give UK-ALL to 2014 along with TKI and MRD is negative, so PCR-BCR ABL 190 is negative, so along with the continuation of UK-ALL, how long would you recommend the continuation of TKI? So you mentioned for blinatumomab along with TKI for 5 years, But if we don't give chemotherapy-free regimen, that is UKLL with TKI, so for how long TKI should be continued if we are not taking that patient to transplant?
Well, thank you so much for your question. So good to see you. So for our patients right now, we are recommending indefinite TKI therapy, even though, I have mentioned 5 years in our other studies with hyper-CVAD, but generally, if the patient can tolerate TKI therapy indefinitely, that's what we are recommending without transplant.
Thank you very
For
much,
sure.
Kiran. Thank you very much. So good to see you as well. So another question, rather comment to the question put forward by Memoona. So regarding the variant of undetermined significance. So as we don't have the database, so the clinical presentation of the patients tell us whether these mutations are of significance or not. I can give 2 examples. We had a family of 3 brothers having platelet function defect, and they turned out to have ABCG5 gene, which is positive in cytosterolemia along with the platelet function defect. But when we got the report from foreign laboratory, they said this is a variant of undetermined significance. But it was of so much of significance in those 3 brothers that we were planning transplant for those patients. So they had so many episodes of bleeding. Another patient who came to us with lots of normoblast in the peripheral blood film and thrombocytopenia, generalized weakness, not transfusion dependent, had 2 different mutations. One was ANKRD26 and the other one was GFI1. Both the mutations are associated with hereditary thrombocytopenias and leukopenias. So we wanted to transplant that patient, and we tested the whole family. He had 2 HLA fully matched brothers, but both the brothers were having the same mutations which were reported VUS. So I think in our population, when we don't have the database and we don't have much of the previous data, so and lots of intermarriages in our part of the world, it's the clinical presentation of the patient which tells us that the mutation is of significance or not. Thank you.
Yeah, so I think this is a very good comment, and as you said, so variants of undetermined significance, you just don't know if they are significant, right? But if you feel that in an individual patient it has prognostic relevance, I would certainly consider transplant in such patients. We just don't know that they are not of any significance, but if later on they can be pathogenic. I mean, you might determine that. So if you feel that in your patient it's of relevance, we would certainly consider that for transplant.
Can I make a comment?
Yes.
So I mean, went to the medical school in Pakistan and partially trained in Pakistan and practicing US. I think molecular tool or molecular data is just one tool that help you make the diagnosis on the clinical side. I think the key thing, especially if the younger audience is sitting, clinical impression is very important, along with the morphology, which is still a gold standard. So we are living in a day and age which is so much data driven, and just looking at the data should not swing our interpretation that we think clinically based on the morphology as well. A quick example is these days, even in the United States, we have a pathology resident who get a blast case with all rods present in it, but they're waiting for the flow to confirm it's myeloid leukemia. So I think there are certain elements on the morphology side. I mean, something that I learned from Pakistan practice was, if I'm dealing with APL and if the simple myeloperoxidase stain is negative, I mean, I can confidently rule out APL, right? I don't have to wait for the PML patient. So coming back to the morphology and the clinical history is still gold standard these days. Back to you.
Yes,
Okay,
Dr. Amjad.
I'm Dr. Amjad Zafar. Thank you for the wonderful talks. I'm basically working in the government setup as well as the private setups. I mean, in private setups, we do have the luxury of the transplants and the bites and stuff like that. But when you come to the government setup, I mean, we are really strained for the resources, and we are, I mean, there are patients who cannot really afford even the TKIs, I mean, let alone the transplant and stuff like that. So my question basically is, if you're treating ALL, I'm Philadelphia negative ALL, and the patient you give, I mean, for most of our patients in our setup, we give hyper-CVAD, we achieve responses in around 80%, the CR in the first 28 to 35 days. in around 80% of the patients, but about 1/3 of them unfortunately relapse, and for them, transplant is not an option because of the resources, And so my question is, if you had to choose some sort of regimen for those patients, what would your preferred choice be? That is one part of the question. Secondly, I mean, there are patients who are Philadelphia positive ALL, and there are lots of them right now. I think in my ward right now we have around 10 patients, and not one of them can afford a transplant, and they cannot afford certainly the bites. My question is, if you had to treat those patients, what would your preferred regimen be? I mean, considering the resources and stuff.
Thank you for your question. So yeah, I mean, certainly for the relapse refractory, unfortunately, I think if I have an option, I'll go with blinatumomab. I mean, and it's going to be 5 cycles, and then after that, you can observe the patient. Ideally, we would have wanted to take the patient to transplant because of high-risk disease, and I don't know if that's something that's a possibility right now for such patients. But the options in the relapse setting are very limited because I'm, expecting the patient already received hyper-CVAD, and that's my go-to choice too for frontline. In terms of Philadelphia positive, I don't know when you say TKI, is imatinib not an option at all, even for such patients, or we do have
imatinib and nilotinib, but I mean there are many patients, right now. I think if there are 10 patients, around 7 of them are not responding to imatinib. They are not going into remissions, so that's an issue for us. I mean, I have offered them ponatinib, but I mean most of them they do not afford really, because imatinib and nilotinib are offered through a government program. They're free of cost. But ponatinib, they have to buy out of the pocket, so they cannot really afford it. So, I mean, we are still really lost here. So on the top of my head, I do not know many regimens which can be really helpful for such patients, So if you had to choose, I mean, for some reason, if we got the funding for ponatinib, what would you offer it with? What would you couple it with?
Oh yeah, definitely I would choose ponatinib if I have an option over any other TKI, and definitely we can start with hyper-CVAD because that's a regimen that is available to be administered to patients. So yes, hyper-CVAD with ponatinib is my go-to choice for my patients.
Okay, would it be
definitely ponatinib indefinitely? Yes.
Okay, would it be mini hyper-CVAD or hyper-CVAD? I mean, because we have seen the data, they say that if you're giving good TKIs, you do not really need intensive chemotherapy. So how about mini hyper-CVAD? Would that be a good option?
That would be a good option. I would say mainly for our elderly population above the age of, if you think they cannot handle hyper-CVAD, but for our younger population below the age of 60, I would still do hyper-CVAD with ponatinib, like the full dose hyper-CVAD with ponatinib. Generally what we do is once they achieve a complete molecular remission, then you can easily reduce the dose of ponatinib from, like 13 milligrams to 15 milligrams, and then continue that indefinitely. As long as they're in a complete molecular remission. Yeah, but for the older population, I would do mini CVD and without the anthracycline in combination with ponatinib.
Thank you.
Yeah.
Thank you, Dr. Naqvi. Dr. Kiran, I have a question for you.
Yes.
You see, we are fortunate in that we have all different regimens or protocols available. There are people who will be using hyper-CVAD as the Americans would do. And we have many hospitals and private setups who will be using BFM 2000 as the Australians and Europeans would do. And then there are UKAL protocols that are widely used as well, particularly in the pediatrics and young adults. So we have all these 3 protocols as per physician's choice and as per the protocols approved in their hospitals. So what we do is do the MRD at, say, for example, in BFM 2000, we do it after induction, after consolidation, and before the protocol M. And since we do not have blina available, and we will only use blina as a bridging therapy towards transplant, so we would need to know if the MRD is positive, and if it is, if it's positive, or it was negative getting positive, or it was positive and now negative, because we have to be stingy, or we have to make sure who are the real eligible patients for the blina. And if we are using hyper-CVAD, as certain hospitals are, as Dr. Amjad just said, they will be doing the MRD after the 6 cycles, as you mentioned as well. But then they don't have blina. So if you are to take them to transplant, then you are aren't you giving them an underpowered treatment? So my question is, when would you do MRD in such cases? And then decide on taking them to transplant early on?
See, my take on this question is that whenever the patients are still MRD positive after 2 cycles of intensive chemotherapy, I start thinking about transplant for such patients. I wouldn't give all 6 because you are beating up the patient. Like after giving 6 cycles, they've received a lot of chemotherapy and then you can have more issues with transplant. I push hyper-CVAD for 2 cycles. When I say 2 cycles, it's not part A, B both. I mean, it's not like, it's basically cycle 1A and cycle 1B is what I'm talking about. And if they're still positive after 2 intensive chemotherapy cycles, I do like to consider transplant and maybe bridge them to blinatumomab at that time. I certainly would not push. Yes, go ahead.
Thanks. And if we don't have blina, we obviously are using flag just to hold off, or some sort of maintenance with methotrexate or mercaptopurine until we can get a donor ready in. So, and blina is actually we're using if our flag is failing as well, and by that time there are funds enough to bridge the patient to the transplant.
Correct. Yeah, anything that would bridge the patient to transplant, that's fine. But I wouldn't keep going with the chemotherapy for 6 cycles and then doing an MRD testing at that point, because I think you have given a lot of chemo, and then I think there will be issues with transplant, more toxicity. So I would ideally test MRD after, I always do MRD testing after cycle 1, like 1A, and then obviously after 1B if the MRD was still positive after 1A. And then think about transplant.
Madam, if I can add one question here. We, the oncologists who are working here in government settings of Pakistan, the basic handicap that we face while treating acute lymphoblastic leukemia is probably the financial constraints. Madam, I always believe that sitting here in Pakistan, we need to devise our own guidelines considering our own available resources. About a year back, we sat with our transplant team, and when we decided at what time we should do our MRD assessment, because MRD is again an expensive test. We don't have much resources available. Even if the MRD comes positive, do we have the availability of blina for every of our patient? That is not possible here in Pakistan. So what we did about a year back, we decided that we are going to check the MRD status post-consolidation state. And at that time, we need to define what are we going to do further on. My question here again from the oncologists who are working here in Pakistan, the thing is, should we do MRD after the induction therapy or after consolidation, considering the fact that we don't have the financial resources of doing MRD after every 1 month? Again, if the MRD comes positive and we don't have the availability of blina, should we go directly to the transplant? Or should we change the regimen in a hope to achieve MRD negativity before proceeding to transplant? And specifically for those oncologists who are working here in Pakistan, what do you suggest? MRD after induction or after consolidation if we have the finances of only doing 1 MRD? If the MRD is positive, don't have the availability of blinatumomab, should we change the chemotherapy regimen in the hope of getting an MRD negative before going for transplant?
So what we practically do is, we do MRD after induction, first cycle, 1A, then we do again after consolidation. So if it's negative after induction, and hopefully negative after consolidation and negative afterwards, and is a Philadelphia negative ALL, then we know that he'll do better on a same intensity treatment. If there is an MRD positive after induction and after consolidation, then obviously we have to intensify the treatment, and we would move to a more intense arm, which I'm sure in UK ALL, it automatically moves. And so as in BFM 2000, it automatically goes to a more intensified arm. And then we look for a donor. And if there's a donor, obviously, we'll take the patient to transplant. And if there is no donor, then these higher risk arms or high intensity arms, they do take the patient. Some of the patients get into MRD negative, and then we maintain them on it until they relapse again, and then we see if we can do anything. Dr. Naqvi, do you have a comment on that?
Yeah, no, I think when you say completion of consolidation, like 8 cycles of hyper-CVAD kind of situation, is that what you usually do in Pakistan?
Sorry?
No. Sorry, you when you said end of consolidation with the hyper-CVAD regimen, that's what I usually use here. Do you do MRD after induction, and then you do after like complete consolidation after all 8 cycles?
No, after induction, 1 cycle, after consolidation.
Yeah.
another cycle, second cycle, which is consolidation, and then the port with the methotrexate and mercaptopurine IVs before that. And then after that, actually, we do it at intervals. And I think these are marked intervals for these, both for UKLL and for BFM 2000. Okay.
No, I agree with this approach. I think that's what we need to do. If we have to intensify, we intensify earlier on, So, I definitely think that's the right approach. You have to do it after induction, as you said, and because that definitely has a prognostic relevance in patient survival and and their outcomes. So yeah, after induction for sure, and then consolidation.
If there are no more questions or comments, we will conclude the sessions. Thank you very much, our moderators and chair and the worthy speakers. Thank you very much.
Thank you very much.
Thank you so much.